Okay, so you should unmute yourself if you're in this breakout room with me. I want to go ahead and unmute. So if everybody in this breakout room with me could unmute themselves, that would include Carmen and Sandra Hernandez, Mark Galley, if you're here, Jenny Chin Hansen, Will Lightburn, and Andy Schneider. Please unmute yourselves. Marion, are you here with me?
I am here with you, Eric.
Okay, great. So Marion and I are your co-pilots for this discussion. We'll be co-facilitating this. As I said, there's going to be a need for having one of you become the spokesperson for this group as we go through and report back out to the group as a whole. So does anybody want to put their hand up and just volunteer? Just say out loud, I'd like to be the spokesperson, or I'm willing to be the spokesperson.
I'd be happy to do that.
Okay, thank you, Carmen. That's great, appreciate that. So Marion, why don't you go ahead and let's get started. We are recording, so the recording feature is on. So I think we're ready to start talking.
Great. So thank you all. It's great to be with you all. Just a note that Eric's going to be recording notes there, which will hopefully be a helpful guide in the report out. Dr. Galley, you're muted and you ought to have access to be able to speak. And we're hoping that each of you members of the commission will take a moment to contribute on both of these topics. The first question, as Eric introduced, was this question of what are the design elements, what are the features that need to be in a new unified system that will reduce disparities and increase equity. So you could think about it as undoing some of the barriers to equity that we have now, or you could think about it as just design elements that really need to be built into a new system to increase equity.
Hi, this is Jenny. Are you just having us jump in?
Yes, and if people don't jump in, we'll catch up with everybody as we go along. Thank you, Jenny, for starting.
Well, this is just a first pass. I just, to preface the fact that I actually operated under a full capitated model for about 25 years by way of just giving background for both Medicare and Medicaid, or Medi-Cal in our instance. And so I have a broad sense of thinking about kind of a shared risk pool, which is, I know, implied in a unified financing. But I think I feel very strongly about having an ability to think of a format.
Susan, I got my picture on. Come here a moment. Maybe this will help you too.
Mr. Stomp, I need you to mute yourself. Jenny, if you could unmute yourself. Thank you so much.
Hey, great. So I think one comment I just want to toss into the pot as a startup is a risk adjustment factor. So on the one hand, the fact that it will be full access, but some way to assure that there is a way to consider risk adjustment, which I know is no small feat, having been a part of that, but it's just like, because otherwise in most systems, if you are highly expensive because of whatever condition you have, providers will avoid taking care of you unless they're, quotes, compensated adequately. So I just want to put that one feature into the pot of assuring an appropriate risk adjusting, as well as a way of having financing address payment for prevention and however that gets done. So one is the complex end, one is the more preventive end, so that people are incentivized to really take advantage of preventive care. So two ends of the spectrum relative.
Absolutely. So I hear incentives for preventive care and appropriate compensation for high needs patients. Really, really helpful. Who else? Mr. Lightburn, can you unmute yourself? I think I see you talking.
My bad, sorry. Please call me Will. Beyond preventive care, I think there needs to be a payment structure that will deal with sort of enhanced services or in lieu of services. that can really sort of address factors sort of that we tend to think of more as poverty consequences, environmental consequences, housing consequences, hunger consequences, and somehow build that into the suite of services that we think of as a health delivery system.
So an expansive understanding of what is covered, I think I hear you say.
Yes.
I appreciate that. Is there another member of the commission who'd like to jump in, or shall I start?
Marianne, I have a direct response to both to what Will Lightburn was saying and what Jenny was saying. I disagree with both of you. I think it's faulty for us to jump first to payment models as a form of addressing health inequity and what the other part of the and reducing disparities. First of all, like when we talk about reducing health inequities, we shouldn't be focused on integration of payments. You know, I agree that integration of care is an important element, but integration of payments through a shared risk pool, and you know, so everybody understands when we talk about shared risk pools, we're talking about ACOs. Those are problematic, and we have no evidence that they actually do what they're supposed to do. Indeed, these types of risk-based payment models, they turn providers into risk-bearing bodies. They pull them away from providing care. And we know from many studies that there are many problems with value-based payments and risk-bearing payments. So we need to move away from that. Now, what I think we can do, and which I think is much easier than talking about payment models in terms of creating an economic incentives for providers, what we should do is eliminating cost sharing, ending private insurance, so that there isn't tiered care, so that everybody has one network with one set of doctors, and with one set of, you know, that every doctor is in the pool for every person, and that nobody has financial barriers to care. Those would be the most impactful types of changes that we could use to end healthcare inequity. And you know, I think with a unified financing system, the role of the system itself is to identify where there are shortfalls in funding, and so that we can have so we can fund hospitals based on need. You know, there are ideas about global budgeting that could ensure that our safety net hospitals are getting the payments that they need, the funding that they need to actually provide for care, without creating these economic incentives that change the relationship between doctor and patient. You know, yeah.
So thank you. I hear you saying no financial obstacles for consumers, a well-compensated system that allows access to a broad or maybe a universal set of providers. I hear that comment. I wonder if there's another, maybe Sandra Hernandez.
Yeah, that'd be great. Can you hear me, Marianne?
Yes, indeed.
Great, thank you. So I'd say a couple things first. You know, building off the presentation we heard from Dr. Angel today, this notion about how we think about public health and prevention, to me, are issues that, if we think about how we got to the disparities we have now, you could argue the fragmentation of public health and prevention from the delivery of services is part of what got us here. And I would argue that the data on fee-for-service was not all that beneficial at all as it related to disparities. We had a fee-for-service system for a long time that created a lot of the problems that we have now in the way that providers actually provide care. So I agree that eliminating any cost sharing should be a goal. I do think that cost sharing is a deterrent, and it's a particular deterrent for low income communities. You know, I think that is certainly a principle that I could agree with Carmen on. I would encourage us to look at the data on shared risk pool and value-based payment and see what the data suggests on that versus fee-for-service, because I think, as Jenny has said, you can do a lot more integrated care when you actually finance things in an integrated way and where there's a risk pool that incentivizes outcomes.
Thank you, Dr. Hernandez. Dr. Galley or Andy Schneider, would you like to jump in here? And in a couple minutes, I'm gonna try and get us to move on to maybe this more concrete second question, but please. Andy, maybe?
Okay, I don't hear Mark, so I'll go ahead.
I don't see him at the moment, so please go.
All right, so I think if we're gonna, whatever approach we end up recommending at the end, it's hard to solve for a problem if you don't understand what it is. And so we're gonna need data systems of the kind that produce the information that Dr. Angel produced for us in the first presentation. And whatever systems of care end up evolving, we need to know how different populations get treated in those systems, right? And that's a lot easier said than done, as Jenny and others I'm sure will tell you. But there have to be functioning data systems, and people have to be persuaded to cooperate with the data systems, both the providers and the patients. And again, that's easier said than done, but without good data that people trust, it's going to be very hard to understand where you've got problems and to intervene, to address them. The second and related piece to this, and I'll be a broken record about this all the way through, is the results have to be transparent. And again, however you organize the care, whoever's delivering it, we have to know how the patients those providers or systems are responsible for are faring. And you're not going to know that unless there's transparency. And the basic point about transparency is if the only people who know what's going on are the people in the system itself or the people contracting with the system, you're not going to get over time good results. You're just not going to get them. Other people have to know, the public has to know, the press has to know, competitors have to know. That is what's going to keep managements honest. And that doesn't happen unless there's transparency. So those two related data pieces.
So I appreciate that, Andy Schneider, and I think it leads us well into this question about what you would look for in the way of outcomes or indicators to know that you are making progress on equity and quality. And maybe, Mark Galley, I think you might have been muted and tried to speak earlier. Would you like to jump in on sort of taking us from the first question to that second one?
Hold on, I'll just add on the first question. Can you hear me okay, Mary?
Yes, indeed. Yes.
Okay. So just a couple things. I mean, again, building on some of the observations that we've had in this COVID experience, I think ensuring that an important equity principle to me will be ensuring that innovations in care delivery are equally accessible to all populations. We often see lower income, more disenfranchised communities get the innovation second or last. And ensuring that we create a system that allows the financing that drives those innovations to be equally accessible to all. I'll lift up the point that Sandra made, that this artificial divide between public health and kind of larger population health issues from the delivery system is, for many of us who sort of do both, it's a hard split to make, and building a system that allows those to be bridged successfully, I think, is also important. And then I know we often think about access issues as being driven by some of the dollars and the incentives, but I also want to make sure as we create some sense of equity or equality in the way things are, the financing is driven, that we make sure that we don't inadvertently create a system where more complicated patients with both pent-up demand and underlying social inequities get manifest in the healthcare delivery to those populations, where providers and others don't end up coming to work for those populations as much as we need them to, because we've learned pretty clearly that some of the issues today under COVID is that in rural communities serving low-income people, primary care practices are struggling more and worse than in other places. And how do we make sure that our financing of healthcare doesn't make those practices even more vulnerable than some of the more sort of urban or with different payer mix practices? So I think, you know, building on some of these lessons that we've seen of the health delivery system getting battered altogether because of COVID, but much more in a disparate way towards those safety net systems that I think many of us are worried about now and before. I can't see the second question, so I'm happy to transition. There you go.
The second question is about what would you be watching? What outcomes and indicators would be looking for to see increasing equity?
Yeah, I mean, I kind of come down to the basics around quality, right? Like things, the very basic quality measures around diabetes, heart disease, you know, the access issues. I think Andy's point around transparency is really, really key, ensuring that some of the same more robust quality sort of tactics and techniques are you know, throughout the systems of care delivery, and not necessarily pioneered or built for, I think, more affluent and what are largely the more robustly insured communities. So I think we do have a really important and solid base for measuring quality and ensuring that they get lifted up equally throughout the delivery system, and that however the financing comes together, that is sort of the bedrock of how we both build payments, incentivize behavior, etc.
Thank you, Dr. Daly. Are there other members of the commission who'd like to add on this, sort of going a little bit more specifically? What are you looking for in terms of outcomes, or what would you be concerned about on these issues of equity, and how do you think about measuring quality?
So Marion, this is Sandra. You know, I guess I would say that what we do now is we talk about the chronic disease burden we see in low-income communities. And when we think about quality, we generally think about, you know, is their A1C under control, or their blood pressure under control? What we really ought to be talking about is the disease burden of chronic disease. Because if we're going to do public health and prevention well and primary care well, what we really should be doing is reducing chronic disease burden. That does mean looking at in lieu of services. It means it looks at food programs, it looks at housing, it looks at exercise capabilities, et cetera. And so I think rather than taking a clinical perspective of are we managing these chronic diseases, really thinking about are we making these populations actually healthier overall.
Terrific, thank you. I just want to note that we've got about 5 more minutes in the breakout room, and I would love to hear on this measurement question from each of the commissioners.
This is Jenny. I could just add something that really picks up on Sandra's point, and that is perhaps that the outcomes are, to her point, not a hemoglobin A1C, but really that people have a steady state of well-being, and then you break them up to what constitutes measures that indicate that, you know, be it a stability in mental well-being, the fact that people can function, they can move about and get services and care when they need it, so that it's not so much the kind of medical clinical component, even though that is one of the tools, that doesn't become the first tool. It is a ability to live a steady, safe, meaningful quality of life, and then breaking them down to some of the elements that are social structures in addition to more traditional clinical structures.
Thank you. Commissioner Comsey or Lightborn?
Sure. So I want to kind of reframe how we're thinking about this, because you frame the question as outcome measures and quality measures, but I think we really need to, I think we really need to look at things like timely access to care, geographical accessibility, making sure that there's a diversity of services available to every person, that we have an appeals process that's accessible to every individual who's enrolled in the system. And I think, I think it's a little, when we're talking about high quality care, we have to make sure that, that clinicians are able to practice using their professional judgment based on the individual's need, and that there are not financial incentives that make them practice in other ways. Again, and I think, oh, I forgot. Somebody mentioned in lieu of services, and I think that's a dangerous way to because in lieu of services implies that we would be addressing social determinants of health through payments to healthcare providers. Those types of issues are best addressed by other social safety net programs like unemployment insurance, those things, and those things need to be fully funded, and healthcare needs to be fully funded. I don't think that payments to providers are the way to incentivize them to think about all these other issues and to integrate care. And I think, I think we need to be looking at something broader than outcome measures.
Thank you. Will Lightborn or Andy Schneider, would you like to weigh in on this?
Personally, I mean, I think that exactly the measures Sandra was speaking to, I think are the ones that appeal to me. And to the extent that there's a way of defining a community's health, ultimately that's what I think we have to move ourselves towards.
Thank you.
So,
Marion, if I could
Sure.
just pop in here again, if you don't mind. It sort of fits into both of these questions, but I don't want to lose it. And that is that we currently have a healthcare workforce that does not remotely look like the people that we're trying to reach through these programs, and that those populations who are historically poorly served. We train people in hospitals. We should not be training people in hospitals. We should be training people in prevention, public health, primary care programs, and really use hospitals as a very last resort, whereas today they are a centerpiece of our cost structure. And so thinking about how we train a workforce to look like the patients we are most trying to reach, to me, is part of what a high quality care system would do. And so thinking about what the tools are to be able to restructure our training programs to be able to get culturally appropriate care is, to me, part of our.
Thank you so much. I'm glad we didn't lose that. Andy Schneider, building on any of these points, but perhaps including this one around defining community health and trying to keep an eye on that.
And Marion, it's a matter of time. We have about 35 seconds left.
okay.
So make it snappy,
seconds.
Andy.
30 seconds. So I guess my pitch is, don't reinvent the wheel. Take a look at some of the existing measures that we've got, see if they work or don't, and build on them. The core set, the child core set, the adult core set that CMS uses and has states report now. If there's something useful there, start with that and then build out from it.
Thank you so much. And Eric, I'm getting a audible that other rooms may be trying to extend ourselves a little bit, so I'm not sure where we are on that. But this group was fantastic in sharing the mic and all contributing in ways that I thought were really helpful. And I think a great foundation for this. And I know I can hear in all your voices that that this matter of equity and this matter of access and community health is core to your concerns. So I thank you for all your comments. And as usual, we've gotten lots of comments on chat as well. And when we sum up this whole meeting, we'll do our best to make all of that available to folks who want to dig a little deeper in the comments we received. Eric, where are we?
We are about a minute away from returning to the main room. We've just extended
Okay.
time for 2 minutes, and so we're
So that
kind of the
means
2-minute warning if you use a
that my rigid timekeeping was unnecessary. If there's somebody who wants to jump in with another comment, it would be fine.
Yeah, I had a comment just so I was clear on this. When I was talking about ending private insurance, and that's the way to address inequality. Just to be clear, I mean that we need to adopt a single payer system, and the kind of this tinkering at the edges through attempts at changing provider incentives is clearly it's like we're already doing that and it's not working. So we need to do single payer, and I think that would be the step that we can is the most critical in ending inequity. And also, are these notes, are you going to send me the notes so when we report?
Notes will be projected
Okay.
for you, although I think that you all had so many good points and Eric kept such good notes, you might have to summarize a bit, but yes, they'll be available on the screen when we get back to the full room, which I think.
Carmen, I'll be sharing my screen so you can, if you'd like, just read verbatim or summarize however you like.
Thank you.
You bet.
Thank you. So thank you all. And, we, the consulting team, always appreciate feedback on process too. So if there are things you think we should do differently in future meetings, we'll do our best to improve.
I like these breakout sessions, Marion. I think it's an easier way to get a lot of things on the table. So I don't know how the others felt about it, but so far so good.
Thank you.
Yeah, I'll echo that, Marion. And I will say it is aided by a graceful and skilled facilitator. So nice job.
I was well coached by my colleagues at LRI. Thank you.